Good morning here in Vancouver, good afternoon in other parts of Canada. I'll be presenting on the progress of my postdoctoral research. I declare that I collaborate with Pacific AIDS Network on projects unrelated to this study. So in sexual health, many studies have examined how different contextual factors, for example, history, environment, politics, and socioeconomics have shaped the implementation of HIV programs. However, there has been less attention to what are the contextual factors that influence the implementation of more comprehensive sexual services for STBBIs or sexually transmitted and bloodborne infections. In the literature, there's been a great deal of debate about the possibilities and limits of service implemented within different policy contexts. And in sexual health, two of these policy contexts have been particularly predominant. One of them is the HIV exceptionalism paradigm, in which the funding and programmatic lens is solely or mostly on HIV. And then we also have a health service integration lens, in which the funding and programmatic focus or lens is not only on HIV, but also on other STIs and bloodborne infections. And in some areas of the literature, you also have a broader communicable disease lens. Now, in implementation studies, there has been a greater attention, especially in the last few years, to context. Of those implementation studies that do look at context, context oftentimes is assumed to be a static dimension with a uniform effect throughout the implementation process. And so the changing function of context, for example, policy context in the scale-up of already implemented services, remains largely unstudied. So with this in mind, I'm working on the GetCheckedOnline context study. For this study, we are aiming to understand how organizations in British Columbia can roll out online sexual health services in effective and equitable ways. And we've set up two aims for this. One is to understand the contextual obstacles and opportunities that have shaped the implementation of GCO, GetCheckedOnline, and I'll speak about that in a moment. And the second one is to learn what it takes to implement and expand GetCheckedOnline in fair and sustainable ways. Now, what's GetCheckedOnline or GCO? And I'm not going to go into a great deal of detail here, but just very briefly and a high level lens into what GCO is. This is a comprehensive internet-based testing service for syphilis, chlamydia, gonorrhea, HIV, and hepatitis C. It is a publicly funded service provided by the Bis Center for Disease Control, and it can be considered as a virtual extension of the in-person provincial STI clinic services. In terms of the timeline of implementation of GCO, it can be characterized with 4 overlapping and interrelated phases, which you can see here in the slide. The program has been under development and implementation and scale up for a little bit over a decade now. Although it was first initially launched in 2014, the development goes back to earlier years than that. And as you can see, there has been a lot of developments and a lot of work to maintain GetCheckedOnline throughout these years. Now, for the study that I'm conducting, we're employing the critical research approach of institutional ethnography, which is a research strategy with a long history in critical and HIV healthcare research. And that this strategy pays attention to people's everyday work processes and how such processes are socially and institutionally organized. So what institutional ethnography does is that it really starts with the concrete experiences of people, and it looks at how those concrete or local experiences are broadly or more broadly organized by other social processes. And the intention is to identify how those larger processes might be shaping concrete everyday experiences so that we can identify them and if needed, change them. My study draws primarily on qualitative data collection techniques, and the data collection for this study was conducted between April 2019 and February 2020. I have conducted 25 individual interviews with provincial and regional stakeholders. On the slide, you can see the wide range of stakeholders that I have had the opportunity to speak to so far. I've also conducted 21 observations of planning and operations meetings regarding the ongoing provincial and regional implementation of GetCheckedOnline. And in institutional ethnography, it's very important to understand what texts or documents people use for the daily work and which texts are influential for how they are able to do their work. And so we've reviewed some of those key texts that people have identified as important to their work. I have conducted inductive and iterative analytical analysis or analytical approaches to identify the work processes and implementation timelines to understand what contextual factors have influenced the implementation of GCO. The temporality of the GetCheckedOnline context study really is in the later phases of the implementation, as you can see here on the slide. And for the purposes of this presentation, the findings that I will speak to in a moment really focus on the first scale-up phase and the second scale-up phase of GetCheckedOnline. So our analysis, our empirical investigation has revealed that the current provincial HIV policy environment fundamentally, but also differently, shaped the successive work of scaling up GetCheckedOnline. So in other words, the initial and subsequent efforts to introduce GCO into new communities were caught between two interrelated yet conflicting public health policy paradigms. And I'll speak about them in a moment. So during the first scale-up, province-wide predominant HIV exceptionalism paradigm encouraged innovative approaches and required HIV prevention and treatment integration. So this mandated provincial HIV programmatic framework enabled implementers to embark on the initial regional scale-up of the GCO. The participants, for example, and our empirical investigation reveals that the Stop HIV initiative, which was later formalized into the From Hope to Health provincial HIV strategic policy framework, really played a major organizing role in the work of scaling up GetCheckedOnline. So the target provincial HIV framework allowed regional implementers to make the case for GetCheckedOnline, but it also really provided the financial and logistical means allocated to meet the policy's HIV testing targets to enable the first scale-up of GCO. Now, during the second scale-up phase, more long-standing health service integration paradigm warranted renewed awareness and need of services integrated horizontally with other STBBIs and other health issues. And it was really this horizontal integration of HIV with other STBBIs that served as a backdrop against which implementers embarked upon the second regional scale-up. This had two different outcomes. It allowed GCO to be introduced to one more community, but it limited expansion within the participated regions. I'll explain in a moment. The Stop HIV infrastructure, for example, during the second scale-up, really enabled the second phase because the implementers were able to draw on the financial and operational resources that the Stop HIV infrastructure provided. So the scale-up was facilitated by that. And here, for example, we can see the critical role of the Stop HIV teams in the introduction of GCO to one more community. Now, at the same time, GCO was not able to be introduced to a second community within a participating region due to the limitations of the target HIV funding envelope. One example that came up during my investigation is that the need for integrated STBBI testing and related healthcare services was repeatedly identified, but co-testing strategies really center HIV and allow for co-testing alongside other STIs and hepatitis C, but not the other way around. And it might be important here to mention that with GCO, the most commonly reported infection during the second scale-up was chlamydia. So in conclusion, what my study is showing is that policy context really shapes the structures of opportunity for the implementation, and in my case, as I have explained in this presentation, for the scale-up as well of programs. And sometimes competing public health policy paradigms, in this work, in this case for GetCheckedOnline, have coordinated the work of scaling up comprehensive testing services across busy regions. So an HIV exceptionalism paradigm programmatically, financially, and logistically enabled the first scale-up of GCO, but it did so only partially during the second scale-up. And so the limits of the dominant paradigm were becoming evident during the later scale-up phases, suggesting the need for financially supporting the health service integration programming that many organizations were already or are already working under. And more broadly, my study illuminates the shifting versus the static role of macro-level contextual factors, such as public health policy, in the successive scale-up of already implemented programs. And I believe this is really important because the studies in implementation studies which have looked at context have tended to be focused on organization-level factors, and indirectly or inadvertently, some of the more macro level factors have been either overlooked or downplayed. So I'd like to finish by acknowledging the funders of this study, as well as the partnering organizations and the co-investigators, as well as the members of the GetCheckedOnline Community Advisory Board and our team's research manager.